life support, an instructor and a course organizer as well. And I'm really delighted to give you this presentation. Thank you, Dr. Easy and Dr. Richard, for inviting me. And so it's a quick overview, and we then will have 10 minutes for any questions. This presentation is based on the 2025 Resuscitation UK Council guidance, and also I've taken into account Government of Nepal's policies as well. So I want to make sure that we follow that. This is the most important slide. If there's one take-home message, is this, which is we know patients, once they have a cardiac arrest, the survival is quite low, depending on whether it's in hospital or out of hospital cardiac arrest. Out of hospital cardiac arrest, only 5% will make it into neurological survivable events, and in hospital it's 20%. But what is important in the chain of survival is we need to recognize when somebody is really unwell, and want to make sure we stabilize them before they go into cardiac arrest. And then the second bit is, if there is cardiac arrest, we want to recognize it and do early CPR. And if that involves early defibrillation or administering medications. Then once we do have return of spontaneous circulation, what we call ROSC, we want to make sure that we look after them well and send them to a tertiary center where they could have more treatment and stabilization. But the key thing here is prevention is better than cure, so recognize when somebody is really unwell. So we're going to talk about that. I put this slide, I don't know, we're all Michael Jackson fans, I suspect, and there's this really famous song that they sang, which is ABC, easy as 1, 2, 3. It's a song, and I basically, with emergency medicine, and I do a bit of ICU as well, this is the most important thing. Emergency medicine by nature, we want simple things, and ABC will save you. Your airway, breathing, circulation. We'll talk a bit about airway and breathing. When would you be worried? So somebody with airway issue, because we want to recognize if there's an issue. So if they have stridor, if they have vomit or sputum, if they're sort of burns victim, you want to see edema, then you potentially know that there's an acute airway problem. For breathing, obviously you will look at the efficacy and effectiveness of breathing. So that's either your respiratory rate, your saturations, lungs, sounds. And if there's an airway problem, we know if it's vomit, you want to suction that up. Otherwise, just simple airway maneuvers that involves chin lift or jaw thrust. For breathing, you want to give them supplementary oxygen, or if you're worried about tension in pneumothorax, early needle decompression. We'll talk about that in a few subsequent slides. This is a video I was hoping to show you, but for the purposes, the airway, simple things saves lives. I know we've all sort of fixed it, like you want to get this person intubated, but regardless, you want to get oxygen to the patient so that the oxygen be delivered to their tissues and their organs. And it's as simple things like chin lift, head tilt, so you want to open the airway, or a jaw thrust. If that doesn't work, then you can go into either nasopharyngeal or oropharyngeal, or get down the airway. And worst comes to worst, we put a laryngeal mask or an LMA. And if you have the expertise, you can go on to an endotracheal tube. But I know there's lots and lots of studies done. You do not necessarily need an endotracheal tube to have ROSC. Even simple airway maneuvers have potentially led to patients having better outcomes. So don't be fixed in saying that they need an endotracheal tube. How about C, D, E? So how do we know there's a circulation problem? So obviously you can look at parameters, physiological parameters in terms of heart rate, your blood pressure, capillary refill. So in somebody who's very arrest, ideally you want to do centrally. For disability, you want to look at GCS. Even with my 17 years of experience, I find GCS breakdown a bit difficult. So what I advocate now for all my junior trainees is just outputs perfect. So outputs stand for, are they alert? Are they responsive to voice? Are they responsive to pain? Or are they unresponsive? And if they're responsive to pain, that's an equivalent of a GCS 8, where you know if somebody's GCS 8, they potentially may lose their hearing. You want to look at the pupils, you want to make sure the blood glucose is fine, you want to do a quick neurological examination to see if they've got any naturalizing signs. So if they can only move the right side, or if there's abnormal extensor or flexor posturing, so then you know they've had an intracranial event. And exposure examination, you want to do a head to toe, see if there's an external bleeding, bruises, rashes, because that may point towards another different etiology, whether it's meningococcus, septicemia or not. So you're going to treat that accordingly. So for C, you want either an intravenous or IO access, because you want to, if they're hemorrhaging, you want to replenish that, so blood, fluids, you can give certain medications. For disability, you can give glucose or certain antidotes if you're worried that they've had a syndrome of opiates or benzodiazepines. And the E depends on what you find. So if you think somebody has got meningococcus septicemia, early antibiotics will be advocated. So that is more important. Early recognize that somebody is going to be unwell, treat them, and then escalate it, ask for senior help. Now, what happens if somebody does lose their cardiac output? So this is a flow chart from the government of Nepal, because they've got a really nice flow chart. But I'm going to break it down. Essentially, this is borrowed from the Research Council. So you've got somebody who is unresponsive, and you're worried that they may be cardiac arrest. So the way to do it, to approach that person, have a gentle shake. Hello, hello, can you hear me? You have no response. We will quickly look at the airway, see if there's any obstruction. There isn't. It's going to open it up with tilt head lift, and I usually go down to the patients, and I want to look, listen, and feel for any signs of life. So I'm listening for air that comes in and out of their mouth and their nose. Feel for the carotid pulse, and I want to see if the chest is rising up or down, because that will indicate whether they've got a respiratory effort. And I'll do that for 10 seconds. And if there's no signs of life, then you know that the patient is in cardiac arrest. That's important. You shout out for help.